to speak. Sorry, sorry. I don't know.
You may like to request your friend circle to log in right now because we are already 11. So I'll just wait for another 3 minutes before we start. Okay, it's 11:05. We will start to record and then we. Good morning, everyone, and a very warm welcome to yet another Empire Hour. And you are seeing May 2022 on the screen. It's because we were supposed to have this session in the fourth week of May, and we had our Anicon at that time. And thank you, everyone. First of all, this is the first opportunity that I am getting to thank everyone for a grand success of Anicon. Thank you, everyone. And thank you for being here on time as well. So today we are going to discuss about learning from errors to prevent harm. And all these things are based on our WHO patient safety curriculum. And this is all being discussed by our first cohort of Annie Patient Safety Fellowship. And today it is being done by Ms. Shani Varghese, one of our Annie Patient Safety Fellow. And she is also the Chief of Nursing at Manipal Hospital, Whitefield, Bangalore, Karnataka. Now, this also goes to say that, the learning is not restricted to any particular level or any particular age. So we can always learn, and about patient safety, any amount of learning is going to fall short. This is my personal experience, and I'm Thankam Gomez. I'm the founder president of Association of Nurse Executives India. So we are going to hear Shiny Work is discussing the topic learning from errors. And before that, we have something very special to share with all of you, and that is actually felicitating a very young nurse, Shruti Prafulla Nandvidkar. She's a staff nurse working at Global Hospital Parel, Mumbai, and we are very, very happy to be welcoming her to this session because Annie is always looking for role models in nursing, and we are so excited to welcome Ms. Srushti here. Srushti, hi, good morning, namaste. Can you unmute yourself? We can't hear you.
Good morning, ma'am.
Good morning, how are you?
Fine, ma'am.
Great, thank you. So, Srishti, before I start speaking to you, I just wanted to say on behalf of Association of Nurse Executives India, we are very, very proud of nurses who show bravery outside the hospital premises. In the hospital, definitely we have a lot of heroic stories, and we have a lot of backup in the hospital when we are working as a team. So I'm very sure that you have been already appreciated, congratulated by your own hospital and many other people. So I'm going to officially welcome you to Annie because we are also going to give you a free lifetime membership to our association, and we hope that will help you to grow in your career and get connected with all the leaders of India. And also tomorrow you are going to be a leader, but today you have already proven that you are a leader when you are outside all alone, and you did something great when you are outside. So Sushti, first of all, welcome once again, and tell us a little bit about yourself.
Good morning, everyone. Before I being started myself, thank you to Annie to give me this platform to speak. My name is Srushti Prafulla Nanvidkar. I completed my GNM in 2016 uh, in Nutan School of Nursing College at Murud Nanga. This is one of college of Ramling Mali. I am passed out 2016. Uh, 1 year experience in Nanavati Hospital in 2018 to 2019, and 2 hour experience in Global Apollo Spectra Hospital and now I am joining in Global Hospital in Mumbai.
Okay. Great. So I am very sure with a very less number of years of experience, what you have done is really, really great. So सृष्टि आप हमें बताइए कि आप जब हॉस्पिटल के बाहर थे तो आपने किसी को सीपीआर दिया है। हम लोग सब सीखते हैं और हॉस्पिटल के अंदर ये ट्रेनिंग बार बार देते हैं कि बीएलएस सीपीआर कैसे देना है, और आप अकेले भी नहीं होते हैं, पूरा टीम होता है, तब भी काफ़ी ट्रेनिंग चलता रहता है। तो आप बताइए उस दिन क्या हुआ, और उसके बाद वो हिम्मत आपको कैसे मिली कि आप अकेले थे तो आप ये सोचा कि मैं ये कर सकती हूँ, ये बताइए। आप यू कैन स्पीक इन हिंदी और इंग्लिश, वॉट एवर यू आर कंफर्टेबल, नो प्रॉब्लम एट ऑल। या
Ma'am. With repeated BLS training and mock drill, code blue mock drill, I am in confidence in my skill. But perform in CPR in public, I was initially scared. I thought 2 minutes should be I step up forward, but my self confidence pushed me forward to do that, to take up confidence to do that now. I thought come from small rural area, but nurses has been made me strong. That day on 1st June, I मैं अंधेरी स्टेशन पे जा रही थी। दैट टाइम आई एम प्लेटफॉर्म में थी, तभी सडनली एक मैन वॉज फॉल इन फ्लोर। दैट टाइम वी गो एंड मैंने देखा वहां पे कि क्या हो रहा है करके, तो मुझे लगा कि वो सडनली कोलैप्स हो गया, वो उठ जाएगा। फिर मैं आगे गई, उसके बाद एक लड़की वहां पे जाके उनको वेकअप कर रही थी कि अंकल उठो, क्या हुआ है आपको। फिर वो नहीं उठ रहा था, फिर मैं अगेन वापस उधर आ गई, देखा उसको कि क्या हो रहा है करके। तो उसका पहले मैंने टैप शोल्डर टैप किया कि अंकल उठो, क्या हुआ है आपको, तो वो रिस्पॉन्स नहीं दे रहा था। उसके टाइम पे हम लोग ने पल्स चेक किया तो पल्स नहीं लग रहा था, इसलिए मैंने बोला कि चलो हम लोग सीपीआर स्टार्ट करते हैं यहाँ पे। तभी पुलिसमैन था, उसको बोला कि आप एम्बुलेंस अरेंज करो, तब तक हम लोग सीपीआर देते। विद इन 15-20 मिनट्स में उनका एम्बुलेंस अरेंज हुआ। फिर हम लोग ने पेशेंट को शिफ्ट किया और वो पेशेंट अभी सेफ है।
ओके ओके, उसके बाद पेशेंट के बारे में पता लगा कि क्या हुआ, बच गया?
नहीं मैम, मैंने नहीं दिखा अभी तक उसको।
It'll be nice. I really hope that that patient survived because of your timely intervention, because we know that more than 80% of heart attacks, they happen outside the hospital, and the more prompt CPR that we can give, more patients' lives can be saved. ये मैं हमेशा सोचती हूँ कि ये ऐसा हो सकता है, right? I would request all of you to keep yourself muted. Oppo Renault, please. Okay, thank you so much. What Sriti, whatever that you have done is such a fantastic, role model type of behavior for everyone, and we are very proud of you. And it also gives me pleasure at the same time to call you a leader on the screen so that I can ask her a couple of questions. So, who's your boss? Jessica ma'am. Yeah, okay. Jessica ma'am, can I have you on the screen, please?
Yeah, hi, good morning, ma'am. And
I
good
couldn't see
morning,
you
Srishti.
on the video. Okay, I can see.
Yeah. Srishti, nice to hear you, Srishti. Bindas baat karne ka, not to worry.
So, Jessica, I just want to have a quick bite from you that how do you feel as a leader that, such great things happen among your staff, and how do you plan to capitalize you know, this behavior that you observed? And yes, I must say that thank you very much to you and Dr. Vivek Tololikar, especially because I have seen him sharing such good stories without any delay in Facebook. So when he posts something, usually I stop and see what is he talking about, whether it is about nurses or any other employee or any other special feat that your hospital has done. So please extend our thanks to your leader, and also thanks to you for encouraging such behavior in your staff, and I must admit that so far the brave hearts have come out of two states, Maharashtra and Tamil Nadu. So I really hope all the other states, I am very sure there are more nurses showing exemplary courage. Something great is happening. So we would love to hear about them, and we would like to showcase them for other young nurses and students to get encouraged and have courage to step up when the time arises. So Jessica, what are your plans?
Yeah, yes, ma'am. So, first of all, I really congratulate Srishti from all of us have really felt so wonderful that our own team member could be so confident and step forward to do such a wonderful deed, especially in a crowded area like an Andheri station. It is not that easy to build up that confidence. So, even if someone collapses in front of me, I would think for 2 minutes, should I step forward? Should I do something? What will the crowd think? Are my skills right? Or will I do the right CPR? Will the patient survive? Will someone come to rescue? So there are multiple thoughts that would come in a person's mind to step forward. And at such a very young age, with around 3 to 4 years of experience, so 2 years she has been in global, and I know she is a very smart girl, outgoing, doing her care very well. But as you well mentioned, to do it in public to build up that confidence, I am really, really proud of Srishti. And more important, so she has set an example to the rest of the nurses. If a girl with 3 to 4 years of experience can do this and be so confident that I can do it, I'm sure reading this example or we spreading this information to the rest of the nurses, they'll also in their lifetime when they come across such incident, I'm sure it will build them confidence to like, okay, she has tried, so our colleague has tried, or another nurse has tried. So it's our moral value, and it's important that we also step forward to rescue someone's life. So this, I'm sure, we in every session of ours now we are speaking to our nurses, so that they then go and speak to their friends and spread the word. Though we put it on Facebook, not sure how many nurses would actually see it, but we are proud that many hospitals nowadays, many nurses across are reading it, viewing it, appreciating it. And same way we are speaking to rest of our nurses. We have other 5 global hospitals, so we have spread the same news across to the other nurses of our 5 hospitals. So she is a role model where it can motivate the rest of the nurses to do such a noble task. And going further, it will also give an importance as to how important it is to have CPR trainings, because some may take it very lightly for the sake of having a certification. Some may take it as a certification, but in real life situation, when someone around you needs a life-saving CPR, so nurses will even understand how important it is to develop these skills so that it will come in practice anytime in hand when you're alone, when there are no people around you, when you know that you can save someone's life, it's in your hands. So it will give a lot of importance to it.
Thank you. Thank you very much, Jessica. And thank you to the Maharashtra Annie chapter as well. Thanks to Ms. Vinci, the president, and you are the vice president, and all the office bearers of, Annie chapter Maharashtra.
Shubhangi,
And
yes.
Shubhangi also, yes. And I really hope that, Sushti will definitely become Annie member, and more young nurses can join us becoming a member and experience these things. And thank you so much for sharing the story. And one last question. Thanks, Jessica. To सृष्टि आप मुझे ये बताइए, आप बाहर इतना हिम्मत दिखाया, तो आपकी कॉन्फिडेंस हॉस्पिटल के अंदर भी उसके बाद बढ़ गई है? अनम्यूट कीजिए अपने आप को।
Yes, ma'am.
नेचुरली आपको वो होने के बाद आपको ऐसा लग रहा है कि अब तो मैं सब कुछ कर सकती हूँ। हॉस्पिटल के अंदर भी आपको कॉन्फिडेंस आई होगी, राइट?
Yes, ma'am.
मैं इमेजिन कर सकती हूँ जब हम कुछ बहुत हटके अलग से जब कुछ करते हो, कि लगता है कि हाँ, काफी हजारों लोग शायद ना करें, लेकिन आपने कर लिया, तो आपको लगता है कि हॉस्पिटल के अंदर भी अब मैं सब कुछ कर सकती हूँ, राइट? या so that's the news for all the nurses out there, that courage at the right time is what nurses are to be, of courage inside the hospital and outside the hospital as well. And thank you, Srishti, for being here. We will be sending you your membership card, and you will receive them, and we hope to see you in all Annie events. Okay, and your photo will also go up on your website under Brave Hearts, under recognition. So there are 3 more Brave Hearts that we have felicitated earlier, so you're going to be the 4th one, and we really look forward to all the chapter heads to find your Brave Hearts in your states and let us felicitate them. Thank you so much,
Thank
Srishti,
you,
for
ma'am.
being here.
Thank
Thank you very much, and God bless you. Take care and grow in your career. Okay,
thank you, ma'am.
and stay
Thank
strong.
you.
Thank you very much. Yep.
Yeah. Thank you,
Thank
ma'am.
you, everyone, on everyone's behalf.
Thank
Srishti, a
you,
big clap
ma'am.
for. Thank you, Rashmi. Thank you. So, my friends, now with Srishti's felicitation out of the way, and now we are getting back to our business at hand for today. That is our Empower Hour, and now I will hand over the Zoom platform to Ms. Shiny Varghese, our Annie Patient Safety Fellow, and also she is the Vice President of Karnataka Annie Chapter and CNO of Manipal Hospital, Whitefield, Bangalore. I think I got all that right, correct? Shiny?
Yes, yes,
Okay.
yes, you are.
Thank you so much, and over to you. I'll be staying off audio, off video, and in case you need any help, I'm right here. Okay. Thank you so much, and all the very best.
Right.
Shiny, you have, it's now 20, so you can take time up to 12:15 or 12:20. Yep.
Right.
We took
Okay.
some time from yours to talk to Srishti. Thank you so much. Yeah. Okay.
Thank you very much. Thank you, ma'am. Thank you, Annie, for having given this opportunity to me. And welcome all of you for this today's session. We are going in depth with topic number 5, which is learning from errors to prevent harm. Right. So let me just quickly share my screen. I hope my screen is visible to all of you.
Yes.
Right. Yes. Yeah. Thank you. So welcome to Annie Patient Safety Fellowship Program in collaboration with Patient Safety Movement Foundation. And Annie is committed to zero harm. Today's topic is learning from errors to prevent harm. And thus says Bill Gates, it's fine to celebrate success, but it is more important to heed the lessons of failure. So the objectives of today's session is to coming to terms with healthcare errors, understanding the nature of errors, learning from errors, and identify the situation and the factors which is contributing to the errors. Right. So before going further, let me begin with a case study. A 3-year-old child was taken to the dentist for a regular routine dental examination, and the dentist has examined the child and handed over the child to the dental hygienist to have the the regular routine cleanup. The dental hygienist who was examined, who again cleaned the mouth, cleaned his teeth, and applied a stannous fluoride gel and handed over as a preventative measure for dental caries, dental decaying, and then handed over a glass of water to the child without explaining what to do with the water. And the child drank the water, where it's supposed to have been spitting it out. So the mother noticed that throughout the procedure, the hygienist was engrossed with conversation. Immediately after the child drank the water, the mother noticed that the child became sweating and complained of giddiness and also started vomiting. When the mother alerted the hygienist, she said, nothing nothing advanced was done. It was just a normal routine cleanup, nothing to worry. But the mother insisted that the child is moved to the pediatric ambulatory care unit, and there was a wait of 2.5 hours. After the 2.5 hours, the child has began to, slip into coma, to sleep. The mother thought it is because of this, time, the child would have been tired and the baby has gone to the sleep, but it was actually a coma. And then people alerted, and then the child had to be directly injected with an ampule of adrenaline to the heart and reverted the child. And then from there, the mother was guided to the emergency department, and there again, and 2.5 hours of wait. And there, the child slipped into coma back again. Everybody jumped in to rescue him, CPR, etc. But the child was succumbed to a cardiac arrest, which was caused by the stannous fluoride toxic poisoning, stannous fluoride toxicity. Yes. So the country's toxicologist said that the child has just ingested 4 times higher than what could, the 1/4 of the amount could be fatal to a child. Right? So here, if we look at this case study and see that how many steps have gone wrong, right? So why are we learning? Why are we discussing this errors? Why are we discussing these incidences? This is purely to understand that in healthcare setting, errors can happen. And we also need to understand the errors, and we need to learn from it, right? And there are various factors which contribute to the errors happening. Here, this mother was insisting that the child is not doing well, but the hygienist was not heeded to that plea of the mother, right? And the hygienist did not explain the step to the child, that what the child need to be doing with the water which was handed over to him. And if the mother would have, if the hygienist would have heeded to the mother's plea, she herself would have organized a transfer of the child immediately to the emergency department, pediatric emergency department, instead of directing to the pediatric ambulatory walk-in clinic, right? Yes, so we need to discuss about these things so that we can learn from them, right? So let us move forward to understand what is an error. In simple terms, an error occurs when someone is trying to do something right, but actually does the wrong thing. Right, so let us see another case study here.
The relationship you develop with the patient is one of the most loving, giving, honest relationships you can have. That person has entrusted you. You've shared the worst and you share the best. I grew up wanting to be a nurse, never wanted to be anything else. I was probably 3 years out of nursing school, and I was working in a cardiac intensive care unit. One of my patients had suffered a large heart attack, and I was in our med room, which was open to our nurses station. And I was laughing and talking with my coworkers and not really paying a lot of attention to what I was drawing up in the syringe. I went into her room and started injecting the medication. And one of the nurses from the desk called out and said, "Gwen, look at your monitor." And her blood pressure had just plummeted. I looked down at my syringe and I realized I had double dosed her. on this very powerful blood pressure medication. I was crying, and the patient actually took my hand and comforted me and said, "Honey, everything will be okay." I'm standing there in the back of the room watching my teammates try to salvage a patient that I harmed. I had potentially killed another human being simply because I wasn't paying attention. It was one of the worst nights of my life. I'll never forget it. We were able to stabilize her. It took about 4 hours. Stayed there about 6 days, and then she did go home. I questioned whether I was fit to be a nurse. Was I morally fit to take care of other human beings if I could be so careless? So I went into grief counseling. I felt renewed. I felt like, okay, this is my fate, to be not only a nurse, but a champion for patient safety. We built one of the first quality circles in my unit, and we looked at medication administration, how we cared for patients, fatigue in nurses. And when a nurse made a mistake, we had a team that would talk with her. We experienced less errors. We developed more processes around checking. We built in redundancy into our systems that we didn't normally have. It took about 3 years to get all of that set up. She came back to our unit about 6 months later, and she was dying. Her heart was so damaged that it just could not sustain her. And I said, "Remember we in the hospital before? I'm the nurse that gave you too much medicine." And I said, "I want to tell you how sorry I am, but I also want to tell you how much I learned." And she reached up and kind of cupped my hands in hers and said, "Honey, I told you it was going to be okay. And as long as you learned something, that was great." Her name was Shirley. And every time I start a new project, I think about Shirley. She has inspired me for a lot of my 30 years in nursing.
Right. These videos are all available in the patient safety videos in the YouTube. Here, Shirley taught a lot of things to Gwen, right? And she understood the mistake, what she has done. And Gwen literally became an advocate, or a crusader or an evangelist for the patient safety issues, patient safety parameters. So there are always lot can be learned from an error. So now let us understand what are the principal types of errors. What is actually an error? Error can be what we ought to do, when we don't do what we ought to do, that is an error. That is an error of omission. And when we ought not to do and that we do, that is an error of commission. So what we need to do when we don't do it, it is called as, it is an omission. And what we suppose not to do when we do, it is a error of commission. Okay, so now these errors are two types, which is skill-based slips and lapses, and also they are mistakes. So when we see the skill-based slips and lapses, that also branches into two: attentional slips of action and lapses of memory. Attentional slips of actions are without our knowledge we have committed that error. So example is that inadvertently during a procedure we pressed a button that caused harm to a patient. And examples of lapses of memory is that because we forgot we just missed a medication administration, a dose is missed because it slipped from our memory. So coming to the mistakes, which are rule-based mistakes and knowledge-based mistakes, like steps from the SOP is missed, or we did not have the knowledge to do the procedure, right? Or the clinician did not have the knowledge to diagnose the condition, and inadvertently resulting in a poor treatment of the patient. Okay, so now when we see that situations, we will see situations which is associated with the error, and also we will see the individual factors which is associated with the error. Let us now see the factors contributing to the patient safety incidents in hospitals, which are inexperience, shortage of time, inadequate checking, poor procedure, and inadequate handovers, inadequate communication. When we see the inexperience, hope all of us are quite familiar with these terminologies, right? Because of these factors, a patient safety incidents can occur, or a patient safety can be breached. Inexperience. Let us go to the inexperience. Like staff who is not experienced is assigned to patient care. That is why it is so important that the privileging of a staff need to be done very diligently. Or a fresher is nominated for the assignment, it is very, very critical that these the fresher candidate is being monitored and evaluated on the procedure. Now, the shortage of time is another reason why the patient gets into harm. Many a times we say that due to lack of time, the checking may not be happening properly, we miss the hand hygiene, or we forget to explain the different the stages of the labor. And inadequate checking. A few steps of checking can prevent thousands of medication errors, right? Inadequate checking can cause dearly to a patient. Crash cart checking, we need to be having these crash carts to be checked every now and then to see that it has been every equipment or every medication which is needed to resuscitate a patient is available, right? So because of the lack of checking, we may be causing a harm to a patient, or we may not be able to revive a patient. And the poor procedure, which could be due to inadequate staffing, inadequate information, inadequate equipments available, right? So before heading towards a procedure, need to ensure that everything which is needed for that procedure is gathered. And next, a situation which could cause a harm to a patient is that the inadequate information. Misinformation, inadequate information, wrong information, all can contribute to a patient harm. This is the handovers at every shift between the caregivers. And when we shift the patient from one area to another, we need to be we need to be talking about the patient. We need to be having the patient handover done very diligently. These things can certainly prevent the patient harm. Why are we talking much ahead of time about these things? Because these are the factors which contribute. So the evidence-based study shows that, or it taught that these are the factors which could contribute to the patient harm. So we need to be proactively looking for preventing these situations, not harming the patients, right? Like we talk about the international patient safety goals, right? We speak about the 6 goals, right? so that we are proactively addressing those issues or creating awareness about those incidences, those occurrences, so that we can prevent the harm. So now next, let us move to the individual factors that could cause harm to the patients. So which is limited memory capacity. So most of the time we want to depend upon the memory, right? But our memory is limited. We cannot just focus on the memory itself. What we need to do to avoid the memory dependence? Write down, right? Okay, now the fatigue could be another cause. Now then stress and hunger and illness could be another cause. Also language and cultural barriers, and also hazardous attitude of the individual. Right. So the limited memory capacity we already have discussed. So we need to take notes. We need to have things documented, right? Every time when we do a procedure, it needs to be legibly marked. And whatever needs to be gathered for the procedure, we need to have it written. Need to have a written document in order to have a handover done. So the fatigue. So we need to see that we need to be in proper shape, proper health in order to care for a patient, right? So the lack of sleep, when you sacrifice your sleep, spending much time on the social media and WhatsApp and things like that, that could result in fatigue. The lack of sleep can contribute as much of harm as from an alcohol consumption. Right? And the stress and hunger and illness again can not, a good thing. Stress, hunger and harm can, hunger and also illness also can cause harm to the patient. And again, the language and cultural barriers. Imagine whatever you speak, the patient won't understand. Whatever the patient speaks, you don't understand. Right? Imagine the dangerous situations what we put the patient into, and then the hazardous attitude of the people, the carers. This is inadvertent. I mean, the people deliberately want to make a mistake, right? So when they are not, when they do not know a procedure, they come forward to do a procedure. When they are not experienced, they say, no, they will do the procedure. These are the hazardous attitudes. So now let us discuss these check-ins, right? These are the acronym which would help us to check on ourselves that whether are we fit in order to perform this procedure? Are we safe enough to take care of our patients, right? These are the acronym you may remember is HALT and I am safe. Right? HALT is derived from the check of hungry. Check in whether you're hungry or you're angry or you're lonely or tired. So that will get us into the HALT acronym. And move on to the I am safe checklist. Whether are you suffering from any illness or am I on any medications which may cause me to drowsy and lack of concentration? Or am I stressed? Have I consumed an alcohol? Or I am too tired? And have I have the experience where I can take care of the patient? Right. So these are these checklists actually help us to be confident to be assigned for a patient care. Now let's move on to ways to learn from the errors. They are incident reporting. Incident reporting, which can be an anonymous reporting or it can be a timely feedback, right? So somebody observed, right? You observed a wrong thing doing for a patient. You don't, without even mentioning your name, you can report it, right? And whoever is the first witnessing of this incident supposed to be reporting it as soon as possible, right? And also the timely feedback, which is like when you have observed a fresher or another staff, which tend to miss the steps of the procedure, you can immediately correct her. As soon as the procedure is over, or as soon as the procedure's next step is missed, if you can correct it, so that immediately the step can be corrected. And the next is that analyze the root cause of the incident. I'm sure the root cause analysis all of us are quite familiar with. And also, what is learned from this root cause and what can be done in order to prevent it in occurrence in the future. That is the reason why we do discuss about the root causes, and also that is why we discuss the incidents are being reported. So the incident reporting always should result in a prevention. Right, so let us look into that. So incidents are sometimes not reported due to the fear of punishment and reprimanding, because that is why we always suggest that we need to have a system approach versus a personal approach. And there is a human factors involved in this, that the fallible human beings are taking care of the another complex individual. So there is an error factor, there is a human factor to the errors are there, but once to err is human, but to repeat this again and again is certainly demonic, right? And then to learn from the error and to devise measures to prevent its occurrence. And also this these discussing of the incidents and the root cause analysis always should create an opportunity to learn from it, and also learn from the near misses. Near misses is that we catch the error before it happens. These are the priceless opportunity to prevent harm. So not only the incident to be reported, but also the near misses to be reported and to be spoken about it in order to create awareness and to learn from it. So now let's see another case study here.
The patient care technician came to me and she told me, I need to let you see this screen. And she showed me the glucometer.
She saw the word high flash on the screen, and that's what she assumed was the result that she had.
She's like, I just feel like my blood sugar is really high. She's like, I don't feel good. I know my body.
And so there wasn't really any suspicion that it would be low. And so when this error message comes up, it kind of confirmed that.
So we rechecked her blood sugar, and the same thing popped up. So I covered her with some insulin and I called the physician, and by the time I got her back in bed, she became like non-responsive.
Ended up being a rapid response and requiring a transfer of the patient to the intensive care unit.
Nurse had misread the glucometer and called the physician, asked for insulin on multiple occasions, and the patient had a severe hypoglycemic event and had to go to the ICU before it was caught.
During the rapid response, we checked the glucose twice, I believe, and the same thing kept popping up, the screen that said glucose greater than 600. The next day is when I received the call that the whole time her blood sugar was actually critically low.
Shortly after this particular incident, another nurse made the same error where the machine it was an actual low value, but the machine read off this alert saying for a high, do X, Y, and Z.
It never came to mind that the glucometer was incorrect. It was probably the worst experience I've ever had in my professional career.
The nurse manager called our human resources department, explained the error. This is what happened. We didn't fully understand the ramifications of this piece of equipment and the message that it displayed. And they said, well, I think you need to suspend her until an investigation is completed.
I felt like I was talked to like a 5-year-old. I wasn't talked to like an adult. I mean, I'm a nurse because I come to take care of people. I come to do my job. I'm very passionate about what I do. And for a long time, it really shook me. Like when I came to work, I was scared to like take care of patients, and I was really apprehensive about everything I was doing. I wasn't really confident anymore. It really shook me to the core.
I questioned it with my boss, and she had the suggestion to invite some of the staff from the Human Factors Engineering Department in MI2 to come over and help us at least evaluate the process.
I got a call from the chief nursing officer at one of our hospitals saying that they had had a case. There was a design issue that might have contributed to the case, and they wanted us to take a closer look at it from a human factors engineering, safety engineering standpoint.
Right. So here, what have we learned is that it was a system approach than to a personal approach. The glucometer was not calibrated properly. So calibration of the glucometer issue, and instead of the low value, it was showing the high value, which resulted in an insulin administration, which again further made the patient's glucose level to go down. Right. So this organization was a progressive thinking organization. So they have done the whatever the steps need to be done and understood that the glucometer company was called and understood that it was the calibration issue. Right. So let us move on to the structured approach to the RCA. This is the root cause analysis. So we need to ask 6 whys and 1 how. RCAs are, multiple factors such as communication, training, fatigue, environment, equipment, rules, policies, and the barriers where we are discussing, right? So when we consider these 6 whys and 1 H, actually what happened? Who was involved? Who was the affected party? When did it happen? Where did it happen? And what is the likelihood of its occurrence? And what are the consequences? And what are the potential harm? And how severe was the actual or potential harm? So when we ask these questions, I'm sure that we will come into we will be able to nail the actual factor which causes the, which was the causative factor, and which could understand and we can address it. So RCA model always focus on prevention. It will never punish or blame the individual, but it always focus on the prevention, and it always focus on the system level vulnerabilities as opposed to the individual level processes. So when we talk to the strategies to reduce the errors, let us be aware when we are tired, and also familiar with the environment we work in, and ask when we are in doubt, and be prepared for the usual, knowing that unusual thing can happen, right? And some personal error reduction strategies it is worthwhile to see. They are, we need to care for oneself, right? We have to be in good health in order to take care of others, right? Need to sleep well, need to hydrate ourselves properly, and also to have nutritious diet, right? And also know your environment, right? Always ask a question when you do not know, right? Ask when you are in doubt. And that is why we ask for the in order to make the environment, the induction. As soon as you join, the inductions are conducted, and also the checking of equipments and checking of crash cards, all that is put in place in order to have you familiarized with your environment, and also know your task, right? Run through your mind before you take up the assignment or before you perform a procedure. And also always have a plan around the procedure. What if something goes wrong? What would I do? Whom will I concentrate? Whom will I escalate this to? Should always have a plan in our mind. Also build checks into your routine. Checklists, the checklists are in order to ensure that the correct steps are being conducted, correct steps are being followed, and also it will give us the cues to forward with the next step. And also when we do not know, when in doubt, always ask questions. So in summary, we have seen that medical errors is a complex issue, but errors itself is inevitable part of us being human. right? Because the fallible human beings, right, the vulnerable human beings taking care of a complex and other human beings, right? And because of the the multiple level of interaction, multiple level of people involved in the care, right, there could be chances of errors, right? There could be chances of issues, because the think about the multiple people which is involved for a patient care. So it is not that one patient is cared by one individual, so multiple people are involved in the care. So it is inevitable, but we need to always focus on correcting it, and also avoid reliance on our memory, right? So keep the checklist ready, right? Always have things written down in order to follow through, and also simplify the processes, standardize the processes and procedures, follow the SOPs, routinely use checklists, and also decrease reliance on vigilance, and also look at errors as the way to prevent and improve, right? Learn from errors to prevent, and also follow the root cause analysis system approach in order to always focus on prevention, right? So that is what we have discussed today, and thank you for your participation. So if you have any doubts and questions, you may ask now, and or else I may hand this mic over to Thangam ma'am. Thank you.
Thank you, Shiny. Maybe you can stop sharing the presentation, and we will now open the floor for any questions or comments. Thank you very much, Shiny, for that, short but in-depth discussion on learning from errors. And I'm very sure that, the participants who are sitting here and those who are going to watch this recording later will appreciate that how much we can improve safety if only we stop to learn from our own mistake. So there is one question that has come here, ma'am. Can you say nurses' role in medication reconciliation? So medication reconciliation is a requirement as per accreditation. The word reconciliation means, trying to tally something, reconcile the accounts, reconcile something else. That means what you had and what you have, you're reconciling. So what does that mean is that you reconcile the medication the patient has at home. The patient is receiving medications in the hospital and when they go home. So let me just make a very small case study which really happened when I was working in a hospital. So there was this patient, elderly patient, a senior lady, I think it was a lady, who was admitted for total knee replacement. Okay, she's a known case of coronary artery disease and she was on a beta blocker. So obviously we all know what beta blockers do. They reduce the heart rate. And so during the surgery, the beta blocker was advised to be stopped. Just before the surgery, they said hold the beta blocker. So the beta blocker was held. And then post surgery, somebody just forgot to restart the beta blocker. So I think after 72 hours, after the patient was transferred out of the ortho ICU, came to the ward, the patient had chest pain. Patient had chest pain with ischemic changes in the ECG. So this is what happens when you stop the beta blocker. There's something called a rebound ischemia that can happen. So those who are from cardiology, they will appreciate this. So the beta blocker was not restarted because of that patient had angina. Fortunately, she did not have MI and the beta blocker was restarted, but the doctor also felt very guilty. And I explained to my nurses what a wonderful job the nurse could have done if she remembered that this medicine is held. What is the action of this medicine? Why this is important for this medication? This is a cardioactive medicine. You don't stop these medications just like that without any reasons. It was held only for the surgery period. it should have been restarted. The nurse could have reminded. So I will not say that's only the nurses. It's a team effort, the doctors, the nurses. So what we then introduced was a chart called medication reconciliation chart. So what happened? On the left hand side, when patient comes for admission, we put all the medication the patient is already taking. So everything is there, so we know that all this medication patient is taking, because many of the elderly patients are on polypharmacy means multiple medications for multiple problems, hypertension, CAD, renal, and other things. And in the middle we started writing all the medicine the patient is currently getting. We kept on adding any other medicines the patient is getting. So you are able to see in the same page whether the medicine the patient needs is being given while the patient is in the hospital, or something is not being given with purpose because there is a need to stop anti-diabetics because the patient is on insulin, or like this case beta blocker was stopped just for surgery. You're able to see that in one form. And the final one had the discharge medication, so that by mistake you don't forget to initiate any treatment that patient should have got when the patient went home. So this entire process is called medication reconciliation. So I'm making it as practical as possible for nurses to understand. So I would always say nurses is the last line of defense. I always maintain that. A smart nurse is a blessing to the patient. She or he is the safety net to the patient at the end of the day, because many people can do mistake, but if this nurse is really smart, she will catch that error. That's how many hospitals are also moving forward and recognizing the best catches. That means nurses who could catch the error before it reached the patient, or even catch the error as soon as it happened, because you need critical thinking, a lot of observation power to even recognize that one need to report these things. And that's what Shiny was trying to explain. If only we could learn from errors. Look at your aviation industry, look at your nuclear power industry. If these industries were like healthcare, I'm sure that many more lives will be lost, because every day one plane crash will happen. In healthcare, every minute a patient is being harmed. So the quantum of harm that is happening in the healthcare is far more than this much safer industries. They are also human beings, but they invest a lot in human factors and errors. And now they have even started asking all the pilots and engineers and everyone to report everything that they find is not safe, so that the industry can look into it and fix it before a flight that we take will crash. I remember reading the case study, I think it is in the WHO patient safety curriculum, in the safety one, that I think Boeing, when it crashed, they found one cable, I think it is called tendon cable, maybe the name is wrong, but they found one cable which was the reason for that crash of the Boeing. And you will not believe it, the moment they found that as a root cause, within few days, every single Boeing in the world was checked, whether that cable is right or not. That is the speed and the diligence with which aviation industry works. And in healthcare, we don't even share the errors between the units. If one unit has got a mistake, they'll say, oh, this is our mistake, so we are not going to talk about it. The other unit will say, aha, error happened there, very good. They think too much of themselves. So we are caught in our own thought processes without thinking. All these are powerful opportunities for us to learn and make patient care safer and aim towards zero preventable harm. There is a whole lot of preventable harm, and you will know from your own experience that many errors that you have faced, you would be telling yourself, oh, this error was possible, it was possible to be prevented. So this is very important because I think in one of the sessions, in one of the earlier topics that we discussed. Oh, by the way, all of you who missed your previous session, please go to Annie's YouTube. You will find all those sessions. And every month we are going to go to the next topic. This is topic 5, and 25th of June we will be coming to the topic 6, and then 7, 8, 9, like that. So there's a couple of more questions. So I'm just trying to say, is there any medication regulation checklist following any institute we should like to share here for reducing medication error? This would be useful for my further study. That is Anisha Vadakepat. Okay, Anisha, my number is 9871798914. Maybe you can send a message to me, and this is something I really love to help. So please, I would like to see. So best catchers approach is implemented here in Royal Hospital MOS. Thanks Sanju for that. A lot of people are definitely taking this as a route to encourage nurses to report more. So let me ask if anyone in the audience has a question or anything to share. We have a few minutes before we wrap up.
Ma'am, Lata here. Good morning.
Yes, good morning, Lata.
So, first of all, I would like to thank Shaini for taking up for this session. Second, I just want to tell it will be very interesting, and all the audience will be knowing that there is errors, but as you told, ma'am, many are very reluctant to report it. So I think that self-reporting, yes, we have to encourage self-reporting, and the RCA, of course, we may have to take it up with RCA, either with a brainstorming session, and understand it should be a process driven, not as a person driven thing. So that is really appreciable to this group. All would have been known and understood very well about it. So thank you for that. Coming to the reconciliation, I think that it is really well explained by you, ma'am. And I just wanted to tell reconciliation today. The question was, is the nurse have any role? Yes, of course, we have the role. But when there is a clinical pharmacist is in the organization, usually nowadays they does the reconciliation, and it is mandated to do every day based for the medications. So that is what they are doing it with clinically correlating with the patient's condition, and they become the postman between the medication and the consultant. But what we had done in Fortis Banagata, we had run a pilot by taking the senior nurses to do the reconciliation under the supervision of doctors, because we wanted, especially during night duty, who will be doing, that was the question mark. So they had ran a program for teaching the staffs, but it was not able to sustain, because I'll tell you why we could not sustain it, because the nurses were keep moving. So I think that the lot of knowledge had to be there about the medication and the clinical condition of the patient. Then only a nurse involvement is really worth doing it. But it is not that we cannot do it, we can do it. That's all, ma'am.
Thank you, Lata, for that information. Yes, to do a proper clinical reconciliation, knowledge of the drug and the patient's condition is mandatory. But maybe we should start with the basic medication reconciliation, so that we don't miss medicine the patient has been taking at home. I mean, that's the classical case study that I have shared, which really happened, and
Yes,
it has happened even again also.
Yes.
So that is also another reminder for all nurses that we must know our patient and we must know the medications patients are taking. That's the only way you will
Thank
be
you,
able
ma'am.
to smartly participate in the reconciliations, knowing that which drug is nephrotoxic, which drug is not good for liver, and this patient has got a problem with kidney and liver, so this medicine may not be good. So that needs a lot of in-depth knowledge about medicine and the patient. Thank you so much, Lata. Anybody else has got any comments or any questions? So this is an opportunity for you to share in case you have some good practices. So there has been a question about medication reconciliation form, and if you think that anyone has one, maybe they can tell that we have one that you would like to share with Anisha. because I think she's doing a study on medication error, so she wants to look at medication reconciliation, so they can help. So if there is no question, if there is no comment, I would like to only stop by requesting all those who are present here that Annie is growing steadily, and I would request that let's make it stronger voice for nurses and nursing in India. It is Association of Nurse Executives India. Most of the leaders in the country are our members. So we would like to see more nurses also joining, the mid-level nurses, the staff nurses, join together, learn together, grow together. That's so that tomorrow the excellence is not an exception. Nursing excellence should become the norm. That is how the healthcare industry is going to give its due position to nurses. So we will meet you again on 25th of June at 11 a.m. and Priyanka Sirshat will be discussing understanding and managing clinical risk. That's the topic 6. And Priyanka is also our Annie's patient safety fellow, and we are very happy tell that we also have shortlisted our next cohort of Annie Patient Safety Fellows 2022-23, and we are hoping that doing these interventions by Annie will contribute to improving patient safety and preventing avoidable harms. And each one of us should carry that responsibility and accountability that let me never harm a patient. And for that, we may not want to harm, but mistakes do happen. And very common reason, many things already discussed in our last few sessions, but from my personal experience, many times either we don't have the knowledge or we don't care. That is also another problem. We already have a ready excuse that why that mistake happened. So we should look at process. That's what Lata told, not at the person. But personally, I should look at myself. Do I have all the skills and the knowledge to be a safety champion for my patient? When the leaders are looking at the errors, we tell not to look at the person, look at the process, the structure. But it's a very wholesome way of approach to improve patient safety. Thank you everyone for being here, and we will see you in the next session on June 25th, same time, 11 a.m. Till then, take care of yourself and take care of your patients. Bye-bye. Thank you,
ma'am.
Shiny. Thank you. Bye-bye.